Continuing with Alzheimer's, what Dr. Alzheimer saw when he looked through the microscope, we now refer to as amyloid plaques and neurofibrillary tangles. The amyloid plaques are a buildup of the protein amyloid beta in inappropriate amounts between neurons in the brain. Everyone has some level of amyloid beta in their brain. That's not abnormal. But it's when it starts building up, clumping together, and destroying the connections between neurons that it becomes a significant problem. Initially, these amyloid plaques accumulate in the hippocampus. That is why the presenting symptom of Alzheimer's disease is lack of memory. Second change that Dr. Alzheimer saw, the neurofibrillary tangles. This is a buildup of the protein tau within the soma, within the cell body of the neuron. And tau is a protein that is usually used to create microstructure for the cell body, for the axon. So if you can see here on this illustration, you have the soma, you have the axon, and then making up the axon, you have these microtubules. And when the microtubules break down, they leave tau laying around to clump up, and that breakdown also happens within the cell body. And the more tau that's there, the more the tau is going to cue the cell structure to break down, creating more tau. So the word for an amyloid-based disease is amyloiditis, and the word for a tau-based disease is a tauopathy. Alzheimer's has both of these things. And also, if you look at the brain of someone with Alzheimer's, you will see what is referred to as general neuronal atrophy. This is the general shrinking of the cortex. We don't know if it's in addition to the plaques and the tangles, or if it's because of the plaques and the tangles. But what you see is, if you look at, this is a coronal slice of the brain of someone that had died of Alzheimer's, you will see that the hippocampi are just hollowed out. They're just big empty spaces. They should normally look nice and tight like these guys over here. You also see that all the gyri are shrunken, all the sulci are widened, the ventricles are widened. So there's just a decrease of cortical tissue over time. The risk factors for Alzheimer's are, well, it's idiopathic a great percentage of the time, but there is if you have a family history of it, then of course you're going to be more predisposed to getting it yourself. Hypertension, poor cardiovascular health predisposes one towards Alzheimer's. And what this comes back to is your cardiovascular system is the system that's responsible ultimately for the health of your brain tissue, for clearing out all the debris in the brain. So the better your cardiovascular health is, the better your brain health is going to be, and the less likely you are to get any brain-based diseases. People with Down syndrome. they have really significant heart problems that usually comes into play and is the cause of their ultimate death, usually in their 40s or 30s. But if they live long enough, they will display Alzheimer's dementia. They will have the plaques and the tangles. People with chronic depression are also more likely to display, to develop Alzheimer's than people who have not had chronic depression. And we don't know if it's the depression that creates the Alzheimer's, the greater likelihood of Alzheimer's, or if the depression is a prodromic symptom of Alzheimer's. So the Alzheimer's is already there. The depression is just an early manifesting symptom. And for some reason, we don't know why, but women are more likely to get Alzheimer's. And also, the more head injuries you have, the more likely you are to develop any brain disease, and that includes Alzheimer's. Early Alzheimer's disease, and some people will talk about Alzheimer's in like 5 stages. That's a little too many stages for me to speak offhandedly about it and functionally about it. So I talk about early, mid, and late stage Alzheimer's, as does, I think, most medical professionals. So it's a shorthand. If I went in and said like tertiary stage Alzheimer's, I don't know if anyone would really understand what I was implying. So to begin with, early stage Alzheimer's, as we've already said, begins with short-term memory problems. Word retrieval problems are going to start showing. Proper nouns. People will forget names. They'll use more general language when they refer to things like it, stuff. My dad says like he says like a doohickey. My dad's like, give me that doohickey. I'm like, the black doohickey. I have no idea what that means. I have to say like, be more specific. And he's like, the black screwdriver. I'm like, all right, I know what that means. So they'll use more general language, less specific language as the disease goes on. And there was a famous author, I can't remember who it was, that developed Alzheimer's. And after her death, they went back and analyzed her novels, and they could see the loss of less common words, less of the loss of more specific words, less common words as the disease progressed over time. They could see that in her writings. Some language processing deficits, not a lot in the early stage, but maybe some difficulty processing detail-heavy language, and certainly executive functioning deficits because of the short-term memory problems. They may display some early personality changes, but in my experience, it's really not until the mid or late stage that behavior becomes an issue. Motor memory is not affected early in Alzheimer's. Procedural memory is not affected. And then Alzheimer's, the early stage, is going to progress to disorientation and confusion. And really, once you get to the point where you are more confused or disoriented than not, we refer to you as being in the mid stage of the disease. At this point, the patient has lost pretty much all abstract thinking capabilities. They are very concrete. Because of the loss of abstract thinking ability, they have a lot of problem-solving deficits. Long-term memory deficits start to appear, as well as short-term that was already there. Disorientation becomes more consistent. Behavior problems begin to manifest more consistently. Anxiety, agitation, delusions, possibly obsessive compulsive behavior. At this stage, they can be physically or verbally aggressive, and that could be in earnest that they're aggressive and they're trying to hurt you because of negative emotion, or like I think I said in class, I had a woman strike me in the face, like backhand me really hard one day, and I don't know, she seemed to think it was a joke. There wasn't any really agitation there, so I didn't see it coming, but I got walloped, and she thought it was hysterical. Sleep disturbances start to appear. Sundowners syndromes start to appear at this point. Sundowners is, you'll see a lot of this in the nursing home. This is when patients present better throughout the course of the day, and then with nightfall, they present with much more significant symptoms. And it can be dramatic. I had a patient that was quite placid and lovely in the day, although he was significantly disoriented. He had no idea where he was, why he was there. His short-term memory was about 3 seconds, maybe. And I mentioned to the nurses that, how pleasant he was to work with. And one of the nurses at the station said, "Why don't you stay after 5? Because last night he got in behind the nurse's station and locked himself in the bathroom and screamed at us all night." So sundowners is a thing, and you do have to time your therapy in accordance with it. At times, they get to the point where they can't really carry on an effective conversation because you really need attention and short-term memory capabilities to do this. You'll be talking to them and you'll see they'll be distracted, they'll look away, and the stream of conversation, they have lost it entirely. They start to need a lot of assistance with their activities of daily living. Their posture starts to change. Wandering behavior becomes more of a significant issue. Now down south, if someone with mid-stage Alzheimer's gets out, you have to worry about them wandering into a lake, maybe and drowning, or just wandering, getting lost in the woods and starving over time. But it's a much more serious issue, say up north, where in the winter, it's so cold, you're not gonna survive the night. And they're not gonna get dressed for the cold before they wander off and get lost. So up north, the wandering behavior of someone with Alzheimer's is a much more serious proposition because they're not going to live long at all, especially during the winter. And this wandering behavior it's possible because they still have they're motorically intact, they're able to move, but they still have procedural memory, so they still know to grab the car keys and automatically can jump in the car, crank it, and drive off. But they have the significant cognitive deficits that come with mid-stage Alzheimer's. They start to show very poor hygiene, and because of their memory and their language problems, they start to ask repeated questions over and over again. Moving into the late stage of Alzheimer's, motor skills start to become significantly affected. Most people in the very late stage of Alzheimer's are going to be bedridden, so loss of ambulation. They have lost bowel and bladder control. They're going to be sleeping a great deal of the time. Communication may be gone entirely. Verbal communication is certainly gone at the very late stage. They become unresponsive to most stimuli. And if they live long enough, they'll just get to a point where the body stops taking food. So their brain, their cognition is gone, their will to eat is gone, and then if the body survives long enough, it'll reach a point where even the motor ability to take food will be lost. And this is how one of my grandmothers died. She, prior to death, she was bedridden. She was really not there. If you really tried to arouse her, you could get her to make eye contact with you, but there really wasn't any verbal communication. You could put a teaspoon of water in her mouth, but it would just roll right down into the airway, and you could hear it rattling in her airway, so she had lost the swallow reflex. And most people with late stage Alzheimer's, if they're going to die in late stage Alzheimer's, they're going to die of the anorexia, the inability to take food, and or maybe some secondary medical issue like bed sores or pneumonia. Here are some videos of how hopefully this will work. This guy looks a lot like someone, an agitated patient going into late stage dementia. It's not going to work for me. Here is a link here. So yeah, my embedded video is not going to play, but they'll follow the link here in your PowerPoints. This is a really great video of a woman in the, I would say, the mid stage where she's disoriented. She really doesn't know why she's in the nursing home, and she's a little bit agitated because of it. It's a good example. There are no medications that can slow the progression of any dementia-producing disease. But there are some medications that pretty much all people with dementia are given at this point, and essentially they're Aricept and Namenda. Aricept is the commercial name, the actual drug name is donepezil. And what donepezil does is it slows the breakdown of acetylcholine in the brain, which is a neurotransmitter, and it improves your use of oxygen in the brain. Namenda is used. This is the one, if you've seen the commercial, it's like there's like a butterfly that comes down and lands on the logo. Aricept is used usually at the front end of the disease, and Namenda is usually the patient usually transitions into Namenda towards the late stage. The actual drug name for Namenda is memantine. And I think we've gotten to a point where we're using these drugs in combination. And they do provide a benefit. Patients will say, early stage dementia patients will say that when they have taken their Aricept, that they're able to focus better. They say it's like the difference between having your glasses on and not having your glasses on. The Aricept really brings everything into sharper cognitive focus for them. But we have no drugs that slow or stop the progression of any dementia-producing disease, any primary dementia-producing disease.